is our lifelong learning platform where you can engage with other students and share the knowledge you gain through different events. For this event, we will also be handing out several LEAP medals. So if you're participating in the marketing skills event, in RX, EPSA, in the student symposium today, and much more, you are eligible to receive a medal, and everyone is eligible to receive the annual Congress medal, of course. We have the EPSA Student Science publication, which will also be distributed at this event, where abstracts of research work that you, the EPSA members, have performed are collected. We will also have the Science Day at this event, where students get to present their research and receive professional feedback. We will have a science excursion, which was very, very popular, so it's good to see. We have the EPSA Science blog, where more science is shared, so make sure to check it out. We have the training project, which, as I explained before, there will be lots of trainings at this event and the graphic recording. And we have, of course, public health and social services. We will also be organizing a public health campaign and a social services activity at this event. And then in regards to our public relations, we have, of course, the EPSA website, where all of the basic information is, the EPSA blog, where you can share what you are doing, not just in relation to EPSA, but on a local level. And of course, EPSA shares what we've been doing. And we have the EPSA Monthly Dose, which is a monthly publication that presents the basics of what's coming in the next months. So if you're interested in getting up-to-date information on what's coming, subscribe to the EPSA Monthly Dose. And we, of course, also have our EPSA newsletter, and this will also be shared at this event, so make sure to check it out. We are present on social media. Our team is already busy tweeting, so if you want to join them in their Twitter discussion, feel free. And we are, of course, also active on other platforms where you can follow us. In regards to mobility, I'm sure a lot of you already experienced a Twinet, where students from different countries visit each other. We have the IMP, which are long-term internships in different European countries. We have the Students' Guide, where you can find information on studies in other countries. So if you're going to study to a different country, you should visit this page to get some help in regards to studying there. And we recently launched a humanitarian mobility project where students will travel to a country to help people out there. In regards to professional affairs, we have our mentoring project where students are paired with professionals who mentor them. We have chats with professionals, which are educational sessions, and a live chat with professionals will be organized on Saturday. We have our career page where basic information on different professions accessible to pharmaceutical students is available. And we recently organized a career week, which is a focused week of online activities aimed at developing students professionally. And we are also active in policy or advocacy, where we aim to represent the opinion of European pharmaceutical students. We collect this opinion through the LSs and other representatives of EPSA members, but also through surveys. So we launch several surveys every year, and you are all more than welcome to provide your opinion through them. And then we release position papers, statements of opinion, talk to other stakeholders, and do many other activities to further represent the opinion. And here on the slide, you can also see some of the topics that we are currently involved in. And lastly, we would like to thank all of our partners. These are our professional partners. Our external collaboration partners, who offer student fees at their events, student awards, webinars, and different scientific opportunities. These are the student partners with whom we share knowledge and organize joint projects and statements. And we, of course, also have corporate partners supporting EPSA and offering different opportunities to our members. And yes, this was EPSA in a very short time frame. If you want to know more, there will be an EPSA Projects and Activities webinar 2 weeks after this Congress, where everything will be presented in more detail. So if you're interested in any of the projects, that's the place to go to find out more about them and how you can get involved in them. And yes, this is a quick thank you from the EPSA team for being here and for engaging with us throughout the year. Okay, and with this, we will now proceed to the actual symposium. Before we start with the first presentation, I will just have some technical information, just since everyone's here, just so we make sure everything runs smoothly this week. So, as you could see today, when you are entering the room, you are required to check in into every session you attend. So you registered for the sessions prior to the event, and yeah, you have your tickets either on your app or on your phone at the moment, because they were also sent as attachments to the email Eventbrite sent to you. And you can, of course, also print them if you want to. Before you enter a room, you should talk to the helping team person in front of the room. You will recognize them in the pink t-shirts, or rose t-shirts, because we're in Bulgaria. And you are the one responsible to collect your check-ins. So they will not be chasing you around. You have to come to them, and they are at every door, and they will check you in. Why do you need to check in? Because we have attendance requirements. So to attend the evening program on every day, you need 75% of that day's attendance. Well, at least 75. You can, of course, go for more. So on Tuesday and on Wednesday, you need to attend both symposium sessions and at least one more session in the afternoon. On Thursday, you need at least 3 sessions. You can choose whichever one you want. On Friday, you need both of the morning sessions, and on Saturday, you need all 3 sessions. So keep those in mind and make sure to collect your check-ins, so in the evening you can join us in the evening program. After the event, everyone will receive a certificate as well. To receive a certificate, you need at least 80% of attendance of the entire program, which means at least 13 sessions, including all 4 symposium sessions. Any complaints related to the certificates are to be sent within 1 month of the release. In regards to attendance rules, be at the activity venue 5 minutes before the activity starts, so it can start on time. If 5 minutes prior to the start of the activity there are still free spots, you can join other activities, which means you registered, let's say for public health campaign, or you wish to register for public health campaign and it was full, you can still try to get in if there are spots. Because sometimes people change, some spots might pop up for some of the activities, but people that actually have the registration will be prioritized. But if there are spots, you will of course be able to join. And if you are more than 10 minutes late to the start of the activity, you will not receive your check-in, because it is very disturbing to the activity and to the speaker. If you need to leave a session for a toilet break, you will need to leave your badge with the helping team at the door, and you will receive it back once you return. Yeah, the same rules apply for the GA attendance, because the room can only handle that many people. The exceptions to the GA attendance are the EPSA team and the official delegates, because yeah, we are part of the General Assembly and have to be there. On Thursday and Friday, when we have elections, the applicants in the EPSA team elections, of course, will be prioritized, and delegation members from associations running to host future EPSA events on Saturday will, of course, also be able to join the General Assembly. And then we get to our educational outcomes competition, as was shared over Facebook. So outcomes of the event will be released after the event. What are the outcomes? They are what you learned during the sessions, during the symposium, workshops, trainings, and so much more. Why are we releasing this? So everyone can gain some of the knowledge that you gained here. So everyone that couldn't attend your sessions, and also people that could not join us at the event. How can you participate? You should share what you learned and experienced with us, so we include it in the educational outcomes booklet. How can you share? You can approach an IPSA team member and show them your notes so they take a photo of them. You can write what you have learned on a piece of paper and bring it to the IPSA merchandise table where they will collect it. You can share the outcomes through an online submission form that will be shared today. And you can also send the outcomes to the email that you see on the slide. And lastly, of course, you can interact with us over social media, and that will count as well. And you can use the official hashtags that are available on the slide. In regards to the awards, because like I said, there will be a competition. The person that will share the most outcomes from different sessions will receive a book that was provided by the IPSA team. The top 5 competitors will be able to write a short testimonial that will be published in the IPSA newsletter. The top 10 competitors will receive a special league medal, and everyone else will receive the normal league medal for participating in the educational outcomes competition. Yes, if you want to be part of the competition, make sure you share your name with us so we know who shared the outcomes. But if you don't want to, you can also share them anonymously, of course. And some extra information for some specific sessions. If you're registered for the science excursion, there will be a meeting in the lobby of the hotel on Wednesday at 8:40 because you're leaving with buses. If you're going to the public health campaign, the meeting is in the lobby of the hotel on Wednesday at 14:30. And if you are attending the sports sessions, bring your regular sports equipment for farm athletics and the President's Challenge, and bring your swimwear, of course, and a full cap for the aqua fitness session. For all of those sessions, the meeting is in the lobby 10 minutes prior to the session, and at 7:45 for the President's Challenge. The Bederava workshop on Thursday will start at 12, not 11:30, like the other sessions in that time slot. And in regards to sightseeing, if you're registered for it and do not attend it, €10 will be deducted from your deposit. Like I said before, at this event we'll also have the IPSA team elections. Nomination forms are available on the IPSA website and with the Parliamentary Council, so if you're interested, there's still time, because the deadline for submitting your nomination is tomorrow at 8:59 CEST, so local time, 8:59 local time. And lastly, we will also have the social media competition. You are all divided into houses. How do you know which house you are in? You check your badge and check the color on the bottom of your badge. The houses are the colors of the Harry Potter houses. The winner will of course then be announced at the Harry Potter evening on Friday, and there will not be one specific winner, there will be a winning house. So make sure you engage as much as possible until Friday so your house can win. How do you participate? Each post with the official SO hashtag brings a point to your house, and the hashtag must describe the activity. So, for example, SO symposium or SO educational for the activity we have right now. You can also get double points if you participate in the President's Challenge, contribute to the event's sustainability, take a photo with an IPSA publication, join the IPSA board and Meet Me Fair poster presentations, and take a photo and share your favorite poster, a photo with the IPSA alumni and or trainers, and a quote from the educational program. Some other information: the IPSA merchandise is available at the IPSA desk in the lobby. Make sure you bring bureaus. For the during the symposium, it will be available in front of the symposium hall. On the other days, it's in the lobby. We will also have the IPSA auction. The items will be shared over the Facebook group early tomorrow, and you will be able to start the bidding over Facebook, and it will conclude during the Harry Potter evening. And we are also, at the moment, still collecting the items for the IPSA raffle. And from tomorrow on, you will be able to buy tickets, and every ticket is winning. So when you will buy a ticket, you will immediately receive your gift. All tickets are winning and cost €2. Proceeds of both of of both auction and raffle go to the IPSA support fund, which supports students that cannot attend IPSA events to attend them. So we pay for a part of their attendance fee and make sure more students can join us here. So it's for a very good cause, so come find us and interact with us in this. And like I said before, we'll have the IPSA board and Meet Me Fair, where you will be able to learn more about what the member associations are doing, and it will be during the breaks in the Symposium GA room, which is here. And to conclude, just some information in regards to lunch and dinner schedules. Because the restaurant cannot host all of us at once, there will be distribution. So yeah, make sure to take a photo of this. We will also share it over Facebook as well. And yes, for today we have lunch and dinner. Tomorrow we only have lunch because the dinner will be at the Bulgarian night venue. Yeah, I still see people taking photos. And for the rest of the week, on Thursday we'll again have lunch dinner. On Friday only dinner because we have sightseeing, and on Saturday only lunch because the dinner will be at the gala dinner. And with this, we've come to the end of the logistics information. Are there any questions in regards to this? Is everyone ready to start the symposium? Awesome. So we'll now proceed to our first speaker, who will present the basic information in regards to NCDs. So I will invite Dr. Ivanka Atanasova, PhD, to present non-communicable diseases, a serious threat of the modern world with focus on asthma.
Thank you. Good morning, everybody. First of all, I would like to thank the organizing committee for this invitation to present here some of my view of these non-communicable diseases. Sorry, thank you. I will go briefly because we are not at time, but I will impress about the topic of your conference, non-communicable disease, a serious threat of the modern world, was your topic. My focus will be on asthma because asthma was one of these non-communicable diseases. You know that NICDs are from clinical, non-clinical are much more epidemiological definition. From clinical point of view, these are chronic diseases, which are diseases of long duration, generally slow progression, but with so many consequences. The four main types, you know, of these NICDs are cardiovascular in the area of cardiology. There are plenty of diseases, but heart attacks and stroke were with great mortality. Also different type of cancer, chronic respiratory diseases such as asthma and COPD. It is interesting about asthma because asthma is one of the chronic respiratory disease also in children population. Also in children and adults. COPD is typical for adults population and diabetes. NSIDs, also known as chronic diseases, are not passed from person to person like infectious diseases, and they are the leading cause of death in the world, representing by statistics 63% of all annual deaths, which is a very great part of these annual deaths. Some of 80% of all these deaths occur in low and middle income countries. This is also a very fact that contributes to the different type of healthcare systems, also the burden of healthcare system, expensive treatment. This is one of the reasons that some of these 80% of deaths occur in these countries. You know the definition of chronic disease and what is typical for chronic disease. They are different from acute diseases, and they have such main characteristic. They are not treatable because they result from an acute infectious cause. They don't result from an acute infectious cause, from premature morbidity, dysfunction, reduced quality of life. Usually develop and progress over long periods of time, maybe some 10 or 20 years, often initially insidious, which is very typical for this. Once manifested, there is usually a protracted period with disability patient or impaired care. What is typical for these diseases? They are complex in etiology because of different causes. There are multiple risk factors like long latency period. They are not infectious origin. With prolonged course of illness, they give functional impairment or disability and curability, and insidious onset, which is autism. You know, you have in the program this WHO epidemiology statistic. This type of disease kills 41 million people each year, equivalent to 71% of all deaths globally. And the first in this statistic is cardiovascular diseases, about near 18 million people annually, followed by cancers, 9 million respiratory disease, almost 4 million, and diabetes, 1.6 million. These four groups of disease account for over 80% of all premature deaths. And this, in the next point, these are the main modifiable risk factors like tobacco use, physical inactivity, harmful use of alcohol, and unhealthy diets, all increase the risk of these diseases. And how to decrease these risk factors is to screen and treatment of these diseases, also as well as palliative care, which are key components to response to this type of disease. Which are the main risk factors? I divide these main risk factors into modifiable behavioral risk factors. These are the tobacco use, physical inactivity, unhealthy diet. Tobacco accounts over 7.2 million deaths every year, also including from the effects of exposure to the second-hand smoke. This is also very important and is projected to increase markedly over the coming years. About 4.1 million annual deaths have been attributed to the excessive to the sodium intake. More than half of the 3.3 million annual deaths attributable to alcohol use are from NSAIDs, including cancer. 1.6 million deaths annually can be attributed to the insufficient physical activity, and this is also very important that these risk factors are modifiable. Metabolic risk factors are well recognized. The metabolic risk factors contribute to the 4 key metabolic changes. The main is the hypertension, the raised blood pressure, the overweight, the obesity, hyperglycemia, the high blood glucose levels, and hyperlipidemia. These are the main metabolic risk factors which are well recognized as risk factors in NSAIDs. But we have also non-modifiable risk factors. These risk factors that cannot be reduced or controlled by intervention. They are all also well-known: age, elderly people, gender, race, and family predisposition, family history, or genetics predisposition of these factors. You can see here the four main diseases which are attributed to great mortality, cardiovascular, and you can see the 4 modifiable shared risk factors are with this cardiovascular disease. Diabetes also, cancer also. For chronic respiratory disease, tobacco use, second-hand tobacco use, also air pollution is a very important risk factor, now well recognized for chronic respiratory disease, especially for asthma. How we can prevent and control NSAIDs? It's a very difficult question because an important way to control these diseases is to focus on reducing the risk factor associated with these diseases. Low-cost solution exists for governments and other stakeholders to reduce the common modifiable risk factors and to lessen the impact of these diseases on individuals and society. It will give a comprehensive approach for all sectors, including healthcare system, financial attributes, transport, education, agriculture programs, planning, and collaborate to reduce the risk associated with this disease and promote intervention to prevent and control them. High impact essential NSD interventions can be delivered through a primary healthcare approach, but evidence shows such interventions are excellent economic investment because it provided early to patients, or they can reduce the need for more expensive treatment, because in this type of disease the treatment is for a long time and it is much more expensive and is give healthcare burden expensive. Countries with inadequate health insurance coverage are unlikely to provide universal access to essential intervention in this area. It is expected that non-communicable diseases management intervention are essential for achieving the global target of 25% relative reduction in the risk of premature mortality from NSDs by 2025 and the Sustainable Development Goals target of a 1/3 reduction in premature deaths from NSAIDs by 2030. It will be expected. Now, I will go very briefly my focus on asthma as non-communicable diseases. Why I give you an example of asthma? Because asthma is a chronic respiratory disease observed in child population, also in old population, in elderly people. Asthma is due to tobacco use and second-hand tobacco use, is also in increased danger of air pollution. This is why I choose to present asthma as one of the non-communicable disease. Asthma is one of these major type of disease. It's chronic disease of the air passages of the lungs, which inflames and narrows them. The statistics give that about 235 million people, very close to 300 million people, currently suffer from asthma. It is a common disease among children, and the strongest risk factors for developing asthma are inhaled substances and particles that may provoke allergic reactions or irritate the airways. We have medication, but this medication can only control the asthma. They cannot treat it successfully, asthma. They can only control the asthma attack. And avoiding asthma triggers can also reduce the severity of asthma. We observed in the last year that 2 or 3 times increased asthma in developed countries, and the severity of asthma was also increased, and the so-called uncontrolled asthma. Appropriate management of asthma can enable people to enjoy a good quality of life. You know very well asthma symptoms. Here I presented as a picture. The clinical characteristics is that asthma is characterized by recurrent attacks of breathlessness and wheezing, which vary in severity and frequency from person to person. This is one of the difficulties in treatment, because asthma has different type, different severity, and different frequency of attack. Symptoms may occur several times, different in person. Some people, some children, they have attacks 1 per day, 1 per week, in the day or at night. They affected individuals, and some people become worse during physical activity or at night. During an asthma attack, the lining of the bronchial tube swell, causing the airways reversibly to narrow and reducing the flow of air out of the lungs. Recurrent asthma symptoms frequently cause also other different symptoms like sleeplessness, lethargy, reduced activity levels at school and work absenteeism. Asthma has a relatively low fatality rate compared to other chronic disease. This is also one of the characteristics of this chronic respiratory disease. What is also important facts about asthma? Asthma is a public health problem not just for high-income countries. It occurs in all countries regardless of the level of development. Most asthma-related deaths occur in low and lower middle-income countries, but the prevalence of the disease is in high-income countries. Asthma is underdiagnosed and undertreated. Sometimes in childhood, in children, the only symptom of asthma is cough. It creates substantial burden to individuals and families and often restricts individuals' activities for a lifetime. Which are the causes of, the fundamental causes of asthma are not now completely understood. There are different risk factors. The strongest risk factors for developing asthma are a combination of genetic predisposition with different environmental exposure, with different inhaled substances. Which are these different risk factors? These are indoor allergens or outdoor allergens such as pollens and mold, tobacco smoke, chemical irritants in the workplace, air pollution, which in the last year increased. Other triggers can include cold air, extreme emotional arousal such as anger or fear, and physical exercise. Even certain medications can trigger asthma. These are well-known aspirin and non-steroidal anti-inflammatory drugs. Also beta blockers, which are used to treat hypertension, heart conditions, and migraine. The urbanization, this phenomenon has been associated with an increase in asthma, but the exact nature of this relationship, it is observed, but the mechanism is unclear. Triggers in the home and environment include also pollution, sulfur dioxide, nitrogen oxide, ozone, cold temperature, high humidity, which are well known, recognized environmental factors. Heavy air pollution tends to cause a high recurrence of asthma symptoms and hospital admissions, and this burden the healthcare system. Smoky conditions release the destructive ingredient known as ozone, causing coughing, shortness of breath, and even chest pain. And these some conditions in sulfur dioxide, which also result in asthma attacks. Changes in the weather might also stimulate attacks. Cold air can lead to airway congestion, constricted bronchoconstrictions, extra secretion of mucus. Humidity also might lead to breathing difficulties for population in some areas. Why it is treated asthma? Why it is difficult to treat? Why it is one of the reasons is that asthma is a heterogeneous disease. Patients respond differently to different treatments, and there is a statement that no, the medication does not fit to every asthma patient. The pathophysiology of disease is well known. In the last year, it is very important to know the two type characteristics of asthma. These two types are endotypes and phenotypes. This is a new look into the asthma, a new look into the mechanism of asthma, especially in severe asthma. What we understood, the phenotypes and endotypes are responsible for asthma severity. This is also one of the reasons for this heterogeneity of asthma disease. Phenotypes, what is this phenotype? Phenotype are observable characteristics of an organism resulting from the interaction between its genetic predisposition makeup and environmental influences, which are relatively stable but not invariable. Endotype is another characteristic, specific biological pathway that explains the observable characteristics of a phenotype. These are new into the understanding of asthma and also the impact of this characteristic on asthma severity. Phenotype plays an important role in decision-making process. We have so many medical guidelines, and despite current guidelines, many patients often receive suboptimal therapy. For patients with severe eosinophilic asthma, inappropriate use of maximum doses of conventional therapies such as inhalatory corticosteroids can cause more harm than good. You know very well as pharmacy students the safety profile of corticosteroids. They give benefits but also have so many side effects. Novel agents to treat asthma, we have in the last 5 years. These novel agents are biological agents. They are monoclonal antibodies such as anti-interleukin and anti-IgE therapies. They have been shown to be especially effective, especially in severe eosinophilic asthma, and have an important role in the treatment algorithm, but are very expensive as therapy. What is important for severe asthma? Severe asthma, almost 50% of patients are with not well controlled asthma, even on therapy. The severe asthma affects between 5 and 10% of patients. These patients are with treatment resistant and significantly affects this type of severe asthma affects schoolwork and activities of daily living. And the healthcare utilization increase with increasing of asthma severity, increase the stays in intensive care units, frequent hospitalization, emergency visits, and this cost much more for the healthcare system. Now, we divide severe and uncontrolled asthma due to different characteristics from clinical point of view. Severe asthma requires high dose corticosteroids, inhaled corticosteroids, plus control medication or systemic corticosteroids. Asthma that remains uncontrolled despite this corticosteroid therapy and control medication we understand as severe asthma. Uncontrolled asthma is other type of asthma with poor symptom control, with frequently and severe exacerbation, more than 2 courses of systemic corticosteroids in 1 year, and very frequent hospitalization and ventilation, mechanical ventilation, and airflow limitation. Now, from a new understanding due to development of clinical immunology, we divide asthma now, the classification asthma in 2 types, the so-called very frequent, the severe asthma, or the so-called eosinophilic asthma is the T2 asthma with specific cells. Other type of classification divide asthma in non-T2 asthma with different cellular markers of inflammation, not eosinophilic but neutrophilia and oxygen. These are the 2 asthma phenotypes. You can see one is the much more in childhood onset asthma is the T2 type asthma. It's allergic or atopic asthma or exercise-induced asthma. But also we have in childhood the so-called late onset eosinophilic asthma, which is much more with aspirin exacerbated or non-steroidal anti-inflammatory exacerbation. But this is typical for the childhood, this T2 type asthma. Another phenotype is typical for adult onset asthma is the non-T2 type asthma. It's with very late onset for women, for instance, in postmenopausal period, with obesity-associated asthma, also with smoking-related neutrophilic asthma. Smoking and tobacco use is also specific for adult onset, late onset asthma, together with the chronic obstructive pulmonary disease, COPD. Here, asthma is divided to the clinical phenotype and endotype, and I explained this that due to endotype, we divide asthma in eosinophilic inflamed type 2 high and neutrophilic inflamed type 1 high. This is a very specific endotype, and this is important to know because this predisposes the severe progression of the disease and give the physician and pharmacist also to choose the right treatment. The clinical phenotype of this phenotype are the atopic allergic asthma, which is typical with eosinophilic inflammation with the early onset, obesity related, and also with late onset due to smoking related clinical phenotype. In childhood, for children, it is very typical in majority of children, and about 15% of adults are typical these allergic eosinophilic asthma, atopy with presence of serum IgE antibodies. Another are the non-allergic eosinophilic T2 asthma with late onset asthma with no IgE reactivity to allergens in the serum. Involves so many typical cells and interleukins and cytokines and macrophages and mast cells and basophils, and this gives the opportunity, these molecular mechanisms with understanding of clinical immunology, give the targets for the pharmaceutical industry of new and successful therapy, but very expensive. Such type of drugs are under development now. Commonly, non-allergic eosinophilic asthma are also associated with different comorbidities. There are well-recognized comorbidities like rhinosinusitis or nasal polyps, which are these are well-recognized comorbidities which are accompanied with asthma. Obesity and gastroesophageal disease are typical for developing asthma. Some of people with obesity and gout, they develop asthma. Sleep apnea, smoking, nasal polyps, vocal cord dysfunction, allergic rhinitis are comorbidities associated with developing asthma in diseases. And some of the new drugs are also in under clinical investigation, clinical studies to treat such type of comorbidities. You know very well these JAIMA-based treatment steps with which we treated now patients with asthma. They are divided in controller choice, preferred controller choice, other controller relief choice in green, and in blue, light blue, we have the reliever. When we have asthma attacks, we use SABA, this is short-acting beta agonist, and low dose inhaled corticosteroids. This was the conventional treatment now with asthma. This difficult to treat non-communicable disease. What we can do is pharmacotherapy now of asthma. We can overall give asthma control. First, we achieve current control defined by strictly examine symptoms, the activity of the person, lung function, and use reliever. And the other goal of asthma treatment is to reduce the future risks by decrease the exacerbation, the loss of lung function, and to decrease the adverse effects of medication. The main part of adverse effects of medication is to the prolonged use of corticosteroids, inhaled or sometimes systemically used corticosteroids. Now, the mediators trigger type 2 asthma are different interleukins, and pharmaceutical industry have these targets now, and we have now new drugs. They are so-called anti-interleukin 5 drugs. Why? Because these interleukins activate eosinophils. Interleukin 4 stimulates beta cells for producing IgE and activates mast cells, and also interleukin 13 acts on smooth muscle to induce hyperimpulsive responsiveness and remodeling of the respiratory system, and also stimulates mucus productions. In the last years, it was a great work done with to recognize which are the biomarkers of severe, uncontrolled, difficult to treat, resistant asthma. These are three types of biomarkers: eosinophils in peripheral blood and sputum, immunoglobulin E, total and allergen-specific, and the so-called fraction of X-called released nitric oxide, which is also biomarkers of difficult to treat asthma. Can biomarkers help to assess the disease? These biomarkers at this time, they may help only with treatment decision. If you have increased levels in immunoglobulin B, it is typical for atopic asthma. They are associated with asthma severity. If you have increase in release of nitric oxide, it is predictive of risk for exacerbation. The same biomarkers predictive of risk for exacerbation is the increase in eosinophil counts in blood and sputum. What type of treatment consideration we have? We have now from 10 years on the market, one monoclonal antibody, omalizumab, which is well-known monoclonal antibody. It is immunoglobulin E blocker, and it may be appropriate treatment, well-established drug for treatment of eosinophilic atopic asthma, also used in children. Shared decision-making is also treatment consideration with patient and treatment choice. No biomarker to predict response to omalizumab. It is now only immunoglobulin E level, but it is not factor in response for this type of therapy. Now we only have conventional therapy, the available options to treat to asthma, which is in prevalence in the adult population. There are different type of bronchodilators. Bronchial thermoplasty, it's a medical device. This is a medical type, not by medication. It's an intervention. And azithromycin is an antibiotic to decrease the mucus production. These are the available options now for treatment of these two asthma. And these are the new targets for the pharmaceutical industry, and there are drugs under investigation on these interleukins, which are well recognized as a triggers in different type of asthma. Now, at this moment, we have approved targeted therapies. We have two monoclonal anti-interleukin-5. These are reslizumab and mepolizumab. Anti-interleukin-5 receptor antagonist, benralizumab, and under investigation on the market, dupilumab, which is anti-interleukin-4 receptor alpha. But we also need to consider patients' comorbidities, which is also important for this type of non-communicable diseases, chronic and very difficult to treat also. Omalizumab is approved for moderate to severe allergic asthma. It is investigated in clinical studies for nasal polyps, comorbidities. Mepolizumab is also approved for severe eosinophilic asthma and a rare disease like eosinophilic granulomatosis pharyngitis. Also investigated for COPD, for nasal polyps. Reslizumab is approved. You see, we have approved monoclonal antibody for severe eosinophilic asthma, which is the so-called Th2 asthma. And benralizumab, the mechanism of action is different. It binds to interleukin alpha chain and decrease the eosinophilic. It is also investigated for COPD and approved for severe eosinophilic asthma. Biologics which are they are not first-line therapy, not conventional therapy, they are expensive therapy, and when to use biologic is the question, because it is overburden of expensive of the healthcare system. 75% of patients with asthma are controlled inhaled corticosteroids with or without LABA. This is beta agonist, long-acting. In different registries, full asthma control is obtained only in 30 to 40% of patients. This is not a very high percent for good control of asthma. This is in different registries in different countries. There is concern about long-term side effects of inhaled corticosteroids, and when children start to use high doses of inhaled corticosteroids. This is not good for their growth. Biologics have been studied in patients remaining symptomatic on treatment and proved efficacy and safety. And early administration of biologics may be discussed on an individual basis, and studies evaluating efficacy of first-line biologics are needed. We have no definite answer when how to evaluate efficacy as a first line. I have some concluding remarks by examining the pathophysiology of severe asthma. Targets can be identified for possible treatment strategies. Now we have only these biomarkers, validated biomarkers, such as levels of eosinophils, IgE, and nitric oxide release. They can be used to help define treatment and possibly predict patients who may be more susceptible to exacerbations. Comorbidities must be factored into the treatment discussion as they can affect asthma control. Control of severe asthma can reduce the need for systemic steroids. These are also systemic steroids. It is also used, but only for 10 days together with inhaled corticosteroids. This heterogeneity of disease and multiple phenotypes and endotypes give very difficult treatment decisions. And we now have several options for patients with severe eosinophilic asthma. This is T2 asthma. The medications targeted to non-T2 asthma is still an unmet need for medicine. We have only biologic agent for the first severe T2 asthma, which is severe eosinophilic asthma. These are what should patient expect from very expensive biological therapy? Improvement in typical clinical symptoms and exacerbations, and in spirometry, which is one of the main diagnostic factors. And you can see that anti-immunoglobulin E, like omalizumab, give improvement in exacerbation symptoms and spirometry. Only very well improvement in exacerbation we can expect from new targeting biological therapy, which are this anti-interleukin 5 therapy. Another effects on biomarkers of this expensive therapy are also observed with decrease in eosinophils in blood sputum due to biological therapy, release of nitric oxide and immunoglobulin E. It is seen by using anti-immunoglobulin E therapy with omalizumab and also other anti-interleukin 4 and 13 therapy. One of the questions very important is can we use biological therapy with effects to decrease the need for oral corticosteroid? Very hope therapy with hope is the therapy with pembrolizumab. This is with the clinical study ZONDA, the results of ZONDA and SIRIUS. These are two types of clinical study that compare mepolizumab and pembrolizumab with placebo and how this biologic therapy decrease the use of oral corticosteroids and decrease the harmful using these corticosteroids. Pembrolizumab gives a much more pronounced decrease in using oral corticosteroids. This is my last slide. Thank you for your attention. We have no definite question how to cope with such severe asthma, which is one of the non-communicable disease also in children population. The mortality is not so high in comparison with other non-communicable diseases, but this type of disease is a very big challenge for treatment and good quality of life. Thank you.
Thank you very much. Do we already have If not, she will be joining us in the panel discussion in the next session, so if you'll have any questions then, feel free to ask. And thank you very much for your speech. We'll now proceed to our next symposium speech, which will be given on the topic of towards a new public health strategy for chronic diseases. Can Pharmacists Lead the Way? And it will be given by Jan de Belli, the PGEU Professional Affairs Advisor and also an IPSA alumnus.
Hello, good morning everyone. Thank you first of all very much to EPSA for the very kind invitation, and so I will address for you the topic on public health strategies for non-communicable diseases. Can pharmacies lead the way? And as a big spoiler, actually the answer I can already tell you is of course absolutely. So very shortly on myself, so that you know who is in front of you. I'm a pharmacist, I'm from Belgium, and I work as a professional affairs advisor at PGEU. PGEU, or the Pharmaceutical Group of the European Union, is the European association representing the national pharmacy associations and chambers across 31 European countries in Europe. And basically we are the association representing the voice of community pharmacists at the European level. So as a professional affairs advisor, what is my role? I'm sort of to say the in-house pharmacist in the office, which is also my colleagues are mainly people with a lawyer's degree or with an economic degree. And my role is really to bring the pharmacy perspective in discussions, to work on the topics of related to public health, e-health, medication safety, pharmacovigilance, work with the European Medicines Agency and so on. And as also Eva mentioned, I'm an EPSA alumnus, and it means that I started my journey in EPSA in 2013, so also not too long ago. Was on the Autumn Assembly in Valencia, where I arrived as a third-year pharmacy student back then, because we at that time were launching the new association from Belgium called VFSO, and I was absolutely impressed with my first EPSA Congress. It was my first international experience, and basically that first experience in EPSA made that a couple of years later I run for the EPSA-Z as Vice President of European Affairs, where I was also working in Brussels for EPSA part-time as an intern in the PGEU, where I work now. So you can definitely see that from my story, you have to really not underestimate the impact that a congress such as this can have on your personal and professional development. So that's my key learning point from today, is that you have to embrace it, that you have to have a lot of fun this week, but also that you have to talk a lot to people and get inspired by that. So after my EPSA journey, I worked 1 year as a community pharmacist in practice. So not everything I'm going to tell you is coming out of a book, it's also coming from my own personal experience. And I worked part-time then for the Belgian Pharmacist Association. But enough about me. So as I said, at PGEU, you can see here the countries represent 31 member states, and also from the EU, but also other countries such as Macedonia, Norway, Serbia, Turkey, and others. And as sort of what is our impact, or which is the amount of voice that we represent 400,000 community pharmacists across Europe, who are working in around 160,000 community pharmacies. And that is a very, very important number that I want you to remember throughout the presentation. Community pharmacies are visited by 46 million citizens every day in Europe. So I think that is already one tip of the iceberg on how important our role can be in non-communicable diseases. So now, on my speech, I'll start with providing you on the policy context of non-communicable diseases at the European level. Okay? So what is the role of the EU, other institutions, and the national member states in developing successful policies? How can they look like, and how are they supported? Going to talk you then through rather general on the community pharmacy contribution to NCD, so what on the principal basis community pharmacy can do and how we maybe are still underutilized. And then I will focus on some more practical case studies of existing good practices which show this role. So we'll start very high level and we then go down to some more practical hands-on examples. So, also the previous presentation has already shown you some key numbers on non-communicable diseases. This is applied to Europe and they are part, or they come from the OECD Health at a Glance 2016. So every year in the EU, approximately 550,000 people of working age, so this is only until 64 years old, die prematurely from non-communicable diseases. This has not only a very big impact on the healthcare system, but also on national economies. Because as you can imagine, if you have all these people who could normally be successful contribution to your national economy, if they die and they have a lot of sick days because of this, it has a huge economic impact. Secondly, the direct cost of mortality to non-communicable diseases is 150 billion euros, or 0.8% of GDP annually, and it potentially can cause over 37 million bad days across the EU, which are done to admissions for these conditions if they're not well treated. Then when it comes to the prevalence of chronic disease, or basically to the risk factors of chronic diseases, that we know, of course, that especially in the last 20, 30 years, it hasn't improved the situation. And as you can see today, more than 1 in 5 adults continue to smoke every day. Another more than 5 adults report heavy alcohol consumption, which is also really not to be underestimated when it comes to having an impact on non-communicable diseases. And more than 1 in 6 adults is obese, with this number still increasing in Europe. Knowing all these figures, knowing that this is a huge impact with still a lot of prevalence of high risk factors, which need a lot of prevention, you can now see that only 3% of today's current healthcare expenditure is directed to disease prevention. So this is a number that is really striking, and it really has to go up. When you say chronic diseases, you also say chronic medications, and when you say chronic medications, you often, unfortunately, also say the risk to poor therapy adherence. So in addition to the numbers I just mentioned, is that poor therapy adherence, which is of course, and because of the frequent comorbidities, which lead to a very high amount of different medications for patients, is a huge risk. It contributes to another 200,000 deaths a year in the EU, and a cost of 125 billion euros in Europe annually. So again, I don't think I have to make the link, and I think you can make that yourself. But when you talk about the role of pharmacists, again, here is an absolute crucial contribution we can make. So also here you see some numbers on what is sort of the prevalence of poor adherence in Europe. Between 4 and 31% do never fill their first prescription. Of those who fill their prescription, only 50–70% take their medications regularly, and this is really, this is a real striking number, because if you are working in the pharmacy as a pharmacist, you ask your patient, how is it going with your treatment? Do you manage to take them? Well, everyone will say, yeah, of course. So we need to go beyond that question, and we need to really try to understand how patients, how is their therapy adherence, but also what are the factors that cause poor adherence. And then more than half discontinue taking them within the 2 years. So I think it shows that, we have today very good medication for the different type of chronic diseases. They are, for many of these treatments, they are not very invasive, and they are not causing that many side effects, but still we see this high impact. So we have to understand the issue, and we have to really find also the appropriate solutions, thinking really from the perspective of the patient. So another trend that is of course not helping in reducing the prevalence of non-communicable diseases is that our societies of course grow much older. I suppose that this graph is a graph that you see in sort of half of all the presentations you already had in EPSA, which is the demographic evolution of our society, but we can't repeat enough how important this trend is, and how we need to adapt also our practice to that. So hospitalizations, it's also known that all the patients have more issues with multiple medications. that also adverse drug reactions can cause much larger impact on potential hospitalizations, and that 90% of adverse drug reactions of all people are preventable. So again, I will not make the link myself to the role of pharmacists, but I think you can think about it yourself. So now a bit more technical. We'll go briefly to this because it's of course much more complex than is on this slide. But this is sort of the general understanding you need to have on the EU health policy context. And with EU now I mean the European Union institutions, European Commission, European Parliament, and so on. So you have to understand that the European Union as an institution or as a body has a limited competence in healthcare. Okay? So it is defined in the treaties of functioning of the European Union, and it says that the European Union, so the European Commission, for instance, has to respect the member states' responsibilities for the organization, delivery, and financing of healthcare services. Although there are, of course, some legal competencies where the EU can influence directly with binding legislation, for instance, when it comes to medicines, medical devices, and then some other stuff, that's blood organ products, etc. So, but of course, it doesn't mean that because the EU cannot make very binding legislation on how national member states should organize their healthcare system, that they can have a very important role in supporting the member states. They have a very complementary role, and this is again defined in the treaties, in fostering good health. So on disease prevention and promotion, they have a very important role in best practice exchange, in facilitating cooperation across the member states and improving their understanding and giving them tools to address it at national level, to protecting citizens for cross-border health threats. These are, for instance, antimicrobial resistance, but also everything that has to do with vaccination. Here also the EU has a rather strong competence in supporting the member states, and it's very important that we have an umbrella body that basically also look at these cross-border health threats that can occur. And of course, here in Europe, we don't have any issues so far, luckily, as Ebola or other epidemics, but of course there the EU would also have a very strong competence. The third important part is supporting dynamic health systems. So everything that has to do with the economics of healthcare systems, also the European Union has here a complementary role. Think about, for instance, the European semester. And they, of course, respect, again, the responsibilities of member states, but they have a very important role in guiding and making appropriate policies in this direction. So as a tools, what can now the European Union concretely do to basically help members in tackling the burden of non-communicable diseases? There's a certain number of tools, and next to for the legal competencies on the areas provided, they also have some non-legal tools that can be very effective and efficient for the member states. The first one is having European indicators and also connected guidelines. These are non-binding, but give, for instance, summarize some best practices across the European Union, and then give some recommendations to member states on how they can organize, on how they can improve some things. Secondly is financing. On research, and as a previous speaker has highlighted, there's a lot of need for also some new therapies and some new innovations to improve the measurement and the treatment of chronic diseases. Also here, the European Union has a role in research funding, but also in project funding. So let's say pilot project at national level, these fall under the EU Health Program, can also receive funding from the European Union. Best practice exchange and facilitating member state cooperation. The European Union here has a separate platform for non-communicable disease, which is a steering group for non-communicable diseases, and they combine or they collect different best practices in the different areas of non-communicable diseases. They make sure that member states can access this easily and set it so that they can learn. On the other hand, they also give advice to the European Commission and to the member states on how to develop effective policies in the area of non-communicable diseases. So that was a bit more technical part of the policy strategy. But when it comes to the content, the European Union strategy very much relates to the strategy and the work of the WHO and the Euro and the UN. They aim to support the member states, and first of all, in the 9 voluntary targets of the UN and WHO by 2025. And here they urge governments to set national NCD targets, because you cannot really resolve something if you don't have a clear goal and a clear idea of how much you want to reduce, for instance, the premature mortality. They develop multi-sectoral national NCD plans to reduce the exposure to risk factors and enable health systems to respond in order to reach these national targets in 2025. As also the previous speaker has highlighted, with health policies in itself, we will not resolve potentially the issue. Chronic diseases, and especially the risk factors connected to chronic diseases, are very much related to policies that occur in other areas, for instance, environmental policies, think about education policies, think about agriculture policies, and so on. So it's very important that whenever we talk about setting building national strategies, we don't just focus on healthcare itself, but we focus also on the areas or the risk factors that can cause it. Again, with this idea in mind that we need to focus more on prevention. And thirdly is measuring. If you don't measure, then you will never know how much you're improving, and you will never know how good you are doing with your current strategy. So that is also a very important principle that they try to put forward to the member states. Then connected to that is also Sustainable Development Goal 3.4, which aims to reduce the premature mortality from non-communicable diseases by 1/3 and promote mental health and well-being by 2030. And this is also something that's often forgotten. Mental health is also can also be seen as a non-communicable disease. It's not because it doesn't have this clinical parameters maybe as clear as, for instance, your blood pressure or as your blood glucose, that we don't have to consider mental health. Because mental health is often very closely related as one of the risk factors, or as one of the factors that can potentially risk the control of the NCDs. So these are indeed these 9 voluntary targets that I mentioned. As you can see, they go into different areas. It's in the premature mortality again that I mentioned. It's on the reducing the harmful use of alcohol, having more physical activity, and so on. I think I will also share with you the slides afterwards. You can definitely also have a more detailed look at these numbers afterwards. So this was the sort of high-level part. I hope that you're still following me. Now we have to look, of course, you as pharmacists, whether you are a community pharmacist, hospital pharmacist, pharmacists working in industry or in any other fields, the pharmacy contribution to non-communicable diseases is, because of the reasons I already mentioned, is crucial, but also often underutilized. Okay? So I'm going to show you what are sort of our key assets as then talking now on community pharmacy. So as I mentioned, 46 million citizens visit a pharmacy in the US every day. Of these 46 million citizens, almost 60% can reach their pharmacy within 5 minutes, and 98% can reach their pharmacy in less than 30 minutes. This makes community pharmacies the most accessible healthcare facilities to citizens in Europe, and therefore, knowing that the different chronic diseases are often very, very long underdiagnosed, because people, I mean, if you have a high blood pressure, if you have, let's say, high blood glucose, you won't immediately feel it. You won't know it, you won't detect it, only when it's too late. So it's very important that we use these accessible healthcare facilities to better start measuring patients on a structured way, and to identify who are the at-risk groups, because indeed, as mentioned also before, factors such as age, gender, and risk factors such as potential genetic relevance in the family is very important, and this information is also available in the pharmacies. So, on the other hand, next to having accessible healthcare facilities, I don't need to convince you that pharmacists are very well-trained healthcare professionals. And we all have an education of more than 5 years or more with a very clinical background, but more and more also very healthcare and patient-centered focused education. So we really need to use these healthcare facilities to better focus on the prevention and the control of non-communicable diseases. So here, very briefly, on the trends in pharmacy services. And so where we used to, as a pharmacy or as a pharmacist, focus on our very medicines expertise-oriented services, such as dispensing, compounding, and providing also medication management more and more. Today we see that also a lot of advanced pharmacy services, which can be seen as patient-centered healthcare services, are becoming more and more recognized and valued by in the different countries. Some examples here are vaccination, providing smoking cessation services, measurement of blood pressure, cholesterol, glucose, and weight, chronic disease management, and early screening and testing. So this is a slide that shows which are currently in Europe the prevalence of the different pharmacy services in the different countries. So this shows how many countries in how many countries these services are already implemented. So as you see, on top is of course the core services that I mentioned, which is indeed the dispensing and the medication review type 1, which is basically the basic review of the appropriateness of the medication of a patient at the point of counseling with your patient. But as you can see, these are all the services that relate to non-communicable diseases. Okay? And as you can see, that is more than half. Okay? So pharmacies already have a lot of services to offer, but you see that also there's a lot of services of these that are at the lower half of the graph, so to say. So there's a lot of room for improvement. And so if you look at different pharmacy services related to non-communicable diseases, because services is just a very general word, but under this umbrella there's a lot of very different type of services that are done. For instance, health screening and referral, divided in 4 sections, is a crucial service for early detection of non-communicable diseases, but is still so much underused in European countries. So, for example, diabetes screening, blood pressure and atrial fibrillation detection, cholesterol measurement, and cancer screening, which is also now increasingly provided in pharmacies across Europe by for instance, the self-test. These are crucial services, again, to detect those people that are maybe not aware, they don't have any symptoms, but they visit the pharmacy regularly, and the pharmacist knows, for instance, the potential risk factors that these patients can have. Secondly, health promotion and education. When we talk about non-communicable diseases, there's a crucial part in self-management and health literacy of patients, which has an enormous impact on their potential progression of disease. And so here pharmacists again have a very important role in providing specific services related to this, not only just when dispensing the medication and providing the appropriate healthy lifestyle advice that is connected, but to specific services such as smoking cessation, weight loss services, which are combined with nutrition advice, and then also participating in public health campaigns, let's say, for instance, to prevent strokes, etc. Medication management, of course, happy that this is part of this type of services. Again, this is really focusing on addressing the poor therapy adherence and reducing the adverse drug reactions. So here there are certain type of services, and I will go more into detail in the case studies. But for instance, the new medicine service is a service that the pharmacist provides structured consultation with a patient, where, for instance, a patient who starts a first-time chronic treatment will have a structured consultation with their pharmacist, where he will talk and explain. They sit down in a private consultation room to talk about the medicine, to talk about the disease, to talk about the potential risk of poor therapy adherence, and so on. So really try to give the patient the full information on the medicine, but also, and this is including structured follow-up, to evaluate later on how that information has worked and if the treatment should be adjusted or not. And medication use reviews, these especially for polymedicated patients, very interesting because the pharmacists will there also again through a structured evaluation and evaluate if a polymedication patient, if all the medicines that he's taking, is it still necessary? Are these medicines still the most effective and safe? And are there no new, for instance, medicines interactions or side effects that have occurred since the start of the treatments? And then you also have some specific structured consultations on adherence. Then third or fourthly is the chronic disease management. This is basically chronic disease management services because it might be quite a vague term. This is basically covering all of the three other services, in which pharmacists really have this holistic approach and have the structured role of guiding the patient in his chronic disease, and not only in his medication, but also in his healthy lifestyle. And so this is something that we see more and more being implemented in Europe. Because, for instance, in countries outside Europe, and Canada is actually a very interesting example. Here in some provinces in Canada, pharmacists have a very, very important role in chronic disease management. It's basically a standard service for chronic disease patients who, of course, are in a certain category. But for instance, there also pharmacists can adjust immediately, for instance, the doses of the medication if they see, based on the structured evaluations, that a certain, let's say, a hypertensive drug is not working strongly enough or has caused unnecessary side effects. So we are 2019, so of course I couldn't leave this without giving you a sort of a sneak peek on what digital can do in non-communicable disease, and I understood that also other speakers in the symposium will elaborate more on this topic, so it will be rather general, but they have, of course, it has enormous potential to play in both of the prevention and management of non-communicable diseases. For instance, in improving quality of care and patient safety by continuous monitoring of the disease state, adherence, and the effectiveness of the therapies, by enhancing multi-professional collaboration and communication, because also, again, this is absolutely key in national strategies for non-communicable diseases, is that not only multi-sectorial, but also within the healthcare system or in the healthcare functioning, that the different actors, the GPs, the nurses, the specialists, the pharmacists, are very closely interacted, and that is only, to my personal experience, effectively possible through having also good support tools that facilitate communication and sharing of information. Thirdly, is, as I mentioned before, to increase responsible health literacy and self-management. Of course, risk connected, because as you know, with digital and health literacy, we also have a lot of websites, apps, you name it, that provide correct information on healthcare, but it's also the role, for instance, of pharmacists to guide patients in using the right tools of information so that they can be more empowered in also taking own responsibility in the management of their disease. Then lastly is personalized healthcare services and improved therapy outcomes. And I think this is absolutely the trend that community pharmacists and also pharmacists working in other areas have to focus on in the coming years. It's to make sure that by using very well the more and more data that are generated, both through apps, but also through the sharing of information that we now have on patients and their disease state, to better use this, as indeed also mentioned in the previous presentation, because every non-communicable or every chronic disease can be very heterogeneous. Everyone has its own parameters, can be genetic parameters, and so on. And also this will impact how the medication will respond in one person to another. Okay? So that is very important, and based on that, we need to much better use clinical decision support systems in the pharmacy, because that's one lesson or one learning point I also want to share with you. Don't think as pharmacists that you should be a walking book. Okay? Of course, it's very important that you have a very good thorough understanding of diseases and medication, but don't think that you should know everything by head when it comes to side effects, when it comes to potential interactions. You therefore have clinical decision support systems in your pharmacy dispensing software. Use them well, and we hope also that in coming years there will be much more efficient use of this in practice, so that you can use your time very much really to invest in patient care and not in basically searching for information that is just right available in front of you. So digital, again, extremely important or extremely promising. It already shows its role in certain areas, but especially it's very important that they are appropriately integrated in healthcare practice so that they can complement healthcare providers but not be used as standalone tools, which, as you I think all know, can have some risks and again do not fit in this sort of dogma that we need integrated and multi-sectoral comprehensive strategies on non-communicable diseases. So I will close with some short case studies. We'll try to be brief. We'll start, and I think this is a very interesting example to show you basically all what I have shared with you in the past couple of 20-30 minutes. Okay? So again, we're going back to the topic of asthma. In Finland in 1994, they understood they had a big problem with their asthma control. Okay? So they had 135 diagnosed asthma patients, but 20% of those had severe uncontrolled symptoms. They also knew that this 135,000 was very underestimated, so that there was a lot of people who were still underdiagnosed, and they had a very high cost of 330 million euros annually. So what did they do? And I'm going to switch to here. They decided to go to very much for an integrated care pathway. And so the government, together with the Finnish Lung Health Association and then the different associations of the healthcare providers, they came up with a strategy on the research and based on the idea that asthma patients need as soon as possible to have appropriate treatment, for instance with a long-active beta-agent and corticosteroid. And so they focused on these four things. Firstly was education campaigns, both to the public as to the primary care, so including community pharmacists. What they did is that they basically trained local healthcare providers to become local asthma champions. So for instance, the pharmacist would receive appropriate training specific for this program on how to interact with asthma patients, what could they do for management, what could they do for their healthy lifestyle advice, what could they do for the early detection and evaluation of the disease state. Then they decided, because this was all very much focused on primary care, and so the general practitioner, community pharmacist and community nurse, to link this with a network of specialists linked with primary care. Because as again was highlighted before, chronic diseases can be very complex, can need very also specialized knowledge. So it's also important that we acknowledge that and that we link up with network of specialists, for instance, specialist doctors in hospitals. Okay? And then, as a last point again, there was a focus on trained self-management for persistent asthma patients. So how did it go with the numbers? In 2016, you see that the number of diagnosed asthma patients got up. You could say, oh, that's bad because there were more asthma patients. No, they were just better diagnosed. Okay? So, and also treatment was started much faster. You see that instead of 20% with severe or uncontrolled asthma symptoms, they got to 2.5%, and that cost almost half in just a period of around 20 years. So that is, I think, very impressive. What they did realize is that, okay, they focused in the asthma program very much on the control of asthma. They didn't really focus so much on prevention. And so they started also to explore other strategies, non-communicable disease strategies for other areas. And for instance, this was their allergy program, which basically started from the lessons of the asthma program. And here you can see that already in the goals that they put forward, there's a much higher focus on prevention, on increasing the tolerance, and also in linking it to the economic risk factors or the economic impact factors, let's say, of the diseases. Okay? So what was now the pharmacy role in this type of programs? So as you can see, today almost all Finnish pharmacies are actively participating. This means that they all had this specific training, or they have a local asthma champion within their pharmacy. They receive the dedicated training, and they not only talk with patients on the management of the medication, but also on the prevention, lifestyle, and the appropriate use of the medication, which of course again for asthma, COPD, with the puffers is of course a very classic example. So next to the asthma program, this was also expanded to other areas. And so there's a diabetes program for pharmacies, a heart program for pharmacies that are already run, as you can see, for some over 15 to 20 years. And they're really pharmacies for the Finnish patient are really recognized as important facilities, as important healthcare providers to talk about their non-communicable disease, the progression, and the medication use. A second example is from the impact of healthy living pharmacies. The 99, maybe you cannot read all the details, but you can read them later. As you can see, the two top numbers, 99% and 98%, is how satisfied patients were with the service. So I don't think that's too bad. And that, for instance, if you look at the 60%, these are the amount of people that would normally have made an appointment with their GP if this was not available. So also in terms of costs, and this is of course a very important example, because also in the pharmacy for patients think about also the economic factors related by skipping a day of work because you need to have an appointment at the doctor where you need to wait maybe sometimes for half an hour, an hour. In the pharmacy, you can just walk in after your working hours without an appointment and just have the service. Third example is the diabetes screening service from Italy. It's called Dia Day, and it's basically it's 1 week where the community pharmacies will, again in cooperation with the local governments and with public health associations active in the field of diabetes, where they will screen patients. And so what they will do is that they will assist them in blood glucose testing that they can do themselves, but also in the validated diabetes risk score test, FID risk, and basically on certain risk factors can already give an idea if a patient should be potentially concerned of developing diabetes or pre-diabetes. So these are the results of 2016 and 2017. More than 160,000 citizens were screened in almost 6,000 community pharmacies, with 4,400 patients who detected may have diabetes. And if you do 4,400 times the money that is connected to an early or a late intervention in diabetes, it's a huge amount. And almost 90,000 cases were suspected pre-diabetes. We're also here, and there's a lot of room still for the prevention of the disease and the disease state. Then, detection of hypertension and atrial fibrillation. I'll hurry up a bit. So here, this was a pilot that was done in 2018, where patients over 50 years of age were screened again for hypertension or atrial fibrillation with the measurement in the pharmacy. It was done in 68 pharmacies, and it covered more than 1,100 people in a 2-month period. So this was a rather small-scale pilot, but is then used to potentially expand it to national level. Okay? So as you can see, again, a lot of patients that had no clue that they were at risk for developing potential hypertension or atrial fibrillation were detected. It shows again that the accessibility and convenience of early detection in community pharmacy is a very important asset. Second last is Denmark. So when it comes to adherence support, here there are 2 services that I already mentioned. The new medicine service, which is initiated in 2016, and then the compliance service, which specifically focused on structured evaluation of medication of chronic diseases patients with chronic diseases who already took their medication for over 12 months and who were suspected to have some issues with compliance. Okay? So how does it work? Both services work as a private consultation between the patient and the pharmacy. Okay? It's always part of initial consultation within the pharmacy. For instance, when a patient just walks in to buy any type or renew its prescription, for instance, buy an OTC medicine, it's invited by the pharmacist for this consultation. They have a first face-to-face consultation as part of the structured evaluation, and then a second consultation that's also interesting can potentially, if the patient wishes, can be done as a video conversation, which again works really well if you talk about convenience of the service. So the purpose is achieving better therapy compliance by providing them with knowledge, good habits, and advice not only on their medicines but also on their healthy lifestyle. And then last one, that's a service that I'm quite familiar with as a Belgian pharmacist. And this service was launched in 2017. It's called the Family Pharmacist Service. Basically, the idea is that just as you have your family physician, if you have your dedicated appointed GP, you also have your family pharmacist. And so one pharmacist and one pharmacy that really has an overview of all the medication you're taking, evaluates this, puts it, makes sure that the patient understands very well how to use it by providing a tailored medication plan. And very interesting is that this medication plan can also be shared electronically with the physician, with the prescriber and the nurses, so that they can also adjust when, for instance, changes occur to the medication plan. So this is really, again, very multi-professional approach to the issue. The results after 1 year were that over 80% of pharmacies were providing the service to patients, and that more than 600,000 citizens, so this is only for chronic patients, this service, and this covers more than one out of 20 Belgian citizens. So you can see it has had a huge successful uptake. So my key takeaway messages for you is, of course, the first one, I guess you know it already, is that non-communicable diseases offer a tremendous challenge for healthcare system and national economies across Europe, that integrated strategies not only with different sectors, but also within the healthcare sector. It has to be done in collaboration with the different healthcare providers, with local governments, with non-governmental public health associations, and that there is a stronger need for more prevention, patient empowerment that would lead to better self-management, a holistic approach, and appropriate integration of innovations in healthcare systems, and not only on digital, but also when it comes to new therapies, etc. Second last is that community pharmacists are uniquely positioned. I hope that you are convinced about that fact, to contribute not only to the management of medication, but also to the prevention and the early detection, and that pharmacy services are increasingly recognized and valued as effective and efficient public health interventions related to NCDs. So I would invite you all, not maybe all, but the ones who are interested to join me in the workshops that are still where I will continue on this topic in a more practical manner. And so this afternoon at 5:30 we'll have a workshop specifically on the services that I just highlighted, so that you can really have a practical hands-on experience with some of these services. I brought some stuff from my pharmacy, such as my blood pressure meter and so on, so I hope that you will be able, I hope we won't detect any potential at-risk patients, but at least if we do, then it shows that also for young people these services are needed. And then on Friday will be a more workshop in the form of a debate, where I really want to trigger you with some key statements on the future of community pharmacy, because we have just released as PGU a new paper on the vision for community pharmacy 2030. So we'd be very interested to hear your views and your opinions, and you don't have to be filtered on them, so that I can also report that back to our representatives from our members. So I think this is a very good chance for you to really engage. And then lastly, of course, as I mentioned before, I think what you have here as a platform is very interesting for your own personal and professional development, but also I know that people that are interested in EPSA congresses and so on are often people who are very proactive and who are very willing to develop not only themselves but also their profession. We really need you as well as community pharmacy profession to develop these services, even if they're not implemented yet in your country, to develop them in your national level. Don't wait for the politics, don't wait until you have but just make sure that for every patient that comes in your pharmacy, that you provide the best possible care, and keep this in mind on what you can mean for them and related to non-communicable diseases. Thank you very much.
Okay, thank you very much, Jan. So I hope you have learned a lot of new information about non-communicable diseases, and now also how we as future healthcare professionals can contribute to management. We will now, of course, first proceed to the coffee break, but when we return, we will continue with the student symposium, where you will be able to share what you already experienced and how we, as the youth, as the future healthcare professionals, can already start working on this. Okay, we're not proceeding yet. Okay. How we, as future healthcare professionals, can already start working on this, since non-communicable diseases are everywhere. I'm pretty sure some of you in this room have already experienced it. But yes, we will continue with this after the break. The coffee break will be until 11:30. I ask you to start returning to the room earlier, so we can start at 11:30 sharp. We'll start with the student symposium, and then we'll continue